All right. Welcome, everybody. Just letting a few people in, getting organized on our side. While we are letting some people in, can I get a thumbs up or a high five? Just making sure that the sound works. Thank you, Sarah. One more thing to add, it looks like everyone coming in is on mute, but if you could just double check that you are when you enter the room, that would be great. Okay. Without further ado, I think I'll just get started. Good evening, everyone. Thank you for taking the time to be with us this evening. Welcome to our foot pain lecture brought to you by Dr. Kurt Whitney. My name is Renee Westmacott. I will be your host for the evening. I'm always around to help with any questions that may come up. You could just write them into the chat box or put your hand up, and then we will answer them when appropriate. Let me start with introducing Dr. Kurt Whitney. Dr. Kurt was born and raised in Calgary. He grew up playing a large array of sports, but in his teens, he decided to transition exclusively to soccer, which allowed him to compete at a competitive level. Dr. Kurt's been with active sports therapy for about 2 years as a chiropractor, and prior to this time, he's been a patient at AST for far too many years to count. In his practice, Dr. Kurt focuses on soft tissue treatment, spinal manipulation, and rehabilitative exercises. He's certified in active release techniques, ART, and functional movement systems, both 1 and 2. But more importantly, Dr. Kurt, we would like to know what hockey team you will be cheering for in the Battle of Alberta. Oh, I think
here, I'll show you. I'll show you real quick who I'm cheering for. Give me 1 second.
Oh, this is going to be great.
I think there's only one right answer, everybody. You know, like,
really, there is. That's fantastic.
There is only one right answer. I feel like if I was born and raised in Calgary and supporting Edmonton, we'd have a pretty big fight on our hands. So
I'm with you as well, as a Calgarian. So that's fantastic. Okay, back to what we came here for. Like I said before, if you have any questions that come up during tonight's lecture, feel free to write them into the chat box. We will also be staying on the line afterwards if there's any further questions. And for now, please join me in welcoming Dr. Kurt Whitney, the Flames fan. Welcome, Kurt.
Okay, so yeah, we'll just kind of jump into it. So yeah, I'll tell you guys a little bit more about me. So yeah, oops, there we go. So yeah, this is me. I went to UBCO. So I graduated with human kinetics in 2015. I worked as a personal trainer at the Glencoe Club for about almost 3 years before I decided I wanted to transition to chiropractic and decided to go back to school in, yeah, it would have been late 2017. And then, yeah, so I did finish my GC there, so my doctorate of chiropractic there. And yeah, so that's me. I'm an Arsenal fan. Like Renee said, I'm a big soccer fan. So I would tend to lean more that way. Arsenal is my team of choice. And if you know soccer, you know that I'm usually pretty sad. So, but that's just because it's the life of being an Arsenal fan. It's the hope that kills us. So to get started, that's me, and we'll just jump into it. So a little bit briefly about the anatomy of the foot. Are you guys able to see my cursor here? There we go. You should be able to see the laser pointer.
Yes, we can.
Perfect. So when we look at the foot here, this is the one here. This is the underside of the foot, top side. Again, kind of like a view from the inside of the foot. And then this one's a view from the outside. With this, we can see there's a lot that makes up the foot. There's lots of little bones. So we've got several in through here. Then we have like the finger portion of the toes, which is out through here. The toes or the finger, oh my goodness. The foot really does mimic a lot like the hand. It's really, really similar. as far as like the generalized structure. So the little bones would be what would create the wrist in the hand. This kind of creates the hind foot right in through here, or midfoot. This creates kind of like what this section would be, kind of like the large portion of the foot. As we get into here, when people say like you stand on the balls of your feet per se, that's right in along here. And this would be where the toe starts itself. So right there, right there. Here, probably back here, these are the tarsals, and these guys up here are the phalanges. Just in case, for whatever reason, I do say anything that we have, like, you guys have been kind of forewarned of what some things might be. If a question comes up where maybe I said a word that we don't know, just pop it in the like the chat, and yeah, Renee can get my attention and we can kind of go from there. And I can clarify if it's something like that. If it's a big question, then we'll leave those to the end, as she said. But yeah, so this is kind of the anatomy of the foot. Nothing crazy. There's not a ton that really we need to delve into here. Just wanted to give you guys a bit of an intro. So big thing here, this is gonna be the movements of the foot. This one I do want to touch on just so you guys do have a bit better of an understanding. I have my leg right here. So the first thing is dorsiflexion. This movement is going to be like that. So when the top portion of the foot moves up towards the shin bone, okay? So that's dorsiflexion. Then we're going to have plantar flexion, which is going down, okay? So the reason they're called for that, the top portion of the foot is the dorsal surface, because I know that I think comes up a little bit later, and the bottom portion is the plantar surface. So yeah, so when the dorsal surface moves up, or the top portion, that's dorsiflexion, plantar flexion is down, okay? Then we're gonna have kind of adduction or internal rotation. So that is if we're looking straight at the foot, we're gonna go like this. So the big toe is gonna move kind of towards the midline of the body itself. Abduction or external rotation is going to be like that. So just where the big toe moves away, or the toes move away from the midline of the body. So midline of the body would be right here. This is our big toe, and we go like this. So I'm going to lower this just so you guys can see the foot a little bit better. Okay, and then inversion. So this is where it can get a little tricky. This is where the bottom of the foot comes in like this. So for the most part, if we have any sort of like sprain, like if you ever hear a sprained ankle, which I'm sure everybody has, this is the most common way that we're going to sprain an ankle, okay? The amount of ability that we can bring the foot or the ankle inwards is a lot more than we can bring it outwards. This section here is the lateral malleolus of the leg, and this is the medial. The medial provides a lot less kind of protection and ability to kind of stop that internal motion. But that's a good thing, because we also need that inversion ability while we're walking, while we're doing a lot of things. That's one of our more important kind of ranges of motion outside of dorsiflexion and plantar flexion. So then we have eversion. So the bottom of the foot actually moves out, kind of like under here. So that kind of where the foot, so right in here through them, for a little bit more of that. So it's dorsiflexion and eversion all at the same time. With it, and again, this see it like the amount of motion. You walk, you naturally dorsiflex. Sorry, you naturally pronate small. But in this, just so we can get a better idea and abduct the foot a little bit. And that when or motions while virtually the act off is going to happen during a little bit, and then we kind of down like this. Trust me, those.
Sorry to interrupt,
About a
Dr.
movement real quick.
Yeah, just a quick question. We're having some kind of audio issues. Yeah, I think we're cutting in and out. So let me see. Yeah, the audio seems to be cutting out. Okay, I wasn't sure if it was just me. If there's any hot tips with experts, sorry to interrupt you, Dr. Kurt, I just want to make sure. All the bars are fine on my side. Am I cutting in and out?
No, no, you're okay.
Okay, and actually you sound better, so a quick hello again. Sorry about this, everybody. I'm just
I just got another note.
okay, we have all the bars on this side. Oh, Dr. Kurt taking a mini break. We're going to put this as a Flames commercial. Okay, maybe explain, let's continue and see if, so actually, before we continue, is my audio cutting out the way that Dr. Kurtz is? If I could get someone to write that in chat, that'd be great. Your audio is clear. Okay, perfect. I wonder, let's go ahead, Dr. Kurt, and then see if it kind of improves. If not, I wonder if it's the earphones, anything along those lines sometimes could be a little key.
Yeah, if we do keep cutting out, I can always just pop these out.
You sound great now.
It sounds okay right now?
Yeah.
Okay. Okay, so was that whole section pretty choppy?
Yes, it was.
Or where should I? Okay, we'll do a quick rundown. Okay, yeah. Dorsiflexion, top of the foot up like this. So we have our shin, top of the foot. Dorsiflexion, plantar flexion. Ooh, we got another in the chat. Okay, just Renee. Okay, so yeah, plantar flexion. Adduction, so internal rotation, so midline of the leg. The foot's going to come inward like this. So obviously this is very drastic. We don't want that to happen. And then abduction or external rotation, the foot's going to go out, like the toes will like that. And then we have inversion, so bottom of the foot going towards the midline of the body. Eversion, bottom of the foot going towards the outside of the body, so away from the midline. Okay. Then pronation is a combination of dorsiflexion, abduction, and eversion. So with that one, so we're going to get a little bit of dorsiflexion, then we're going to get a bit of abduction away with a bit of eversion. So just like that. So it kind of flattens the bottom of the foot. Okay. With supination, we're going to end up with some plantar flexion. So bottom of the foot goes down. Then we end up with a little bit of adduction with a little bit of inversion. Okay. So both the pronation and the supination portion of the movement are really important for our gait cycle. So they allow us to provide propulsion or stability within the foot as we're kind of moving that around. Or as we're like taking our step, okay? So we'll move on from there. Hopefully we were able to kind of piece everything together from when it was cutting out to now. So hopefully we're doing a little bit better.
Yes, I think we are, thank you.
Okay, good. Alrighty, so we'll move on. So this is the gait cycle itself. Get my laser pointer back, good. So the stance portion, so if we're using our left foot and then our right foot, let's say the left foot is the one that's standing, the right foot is the one that's swinging. The stance portion with per foot, so if the right foot to right, so yeah, left side is going to be 60% of the stance is going to be make up 60% of the step itself. And then the swing is the other 40. So that's where we get our whole aspect of gait. So traditionally you would go from, as we see here, so with this, so the initial contact, so the heel striking, move into the foot is flat, mid stance. So this is where our stance face starts here, goes all the way to here. Heel still there. Once we toe off, now this is our swing. So that's that last 40%. Okay. So everything's based off of 1 foot as far as how gait's concerned. And then, so yeah, heel strike is the big one. That's where the heel's touching down. Mid stance is where the foot's nice and flat and tends to be where that the opposite foot will actually start to initiate the swing phase. Sorry, my cat is coming close to me and I'm nervous he's going to jump on the computer. Okay. So, and then once we heel off, that is the initiation of that swing phase. Okay. So with heel off to toe off, mid swing, heel strike again. So that would be the complete gait phase itself. Yeah. So one step would be the point from where the toes leave the ground to when the heel strike occurs again. Oh, yep, he's jumping up. Sorry. One full stride would be heel strike to the next heel strike. Okay. And in the portion where we have, sorry, the heel strike to where the mid stance occurs, that's when we're going to find the pronation of the foot is happening. Sorry, he's trying to come say hello to everybody.
We like cats and we could see his tail.
Can see his tail. So the heel strike to the mid stance is where we're going to have the foot pronating. So that allows for almost like a shock absorption within the foot. That's also tends to be where we, like, so in cases like plantar fasciitis or something like that, that tends to be the most painful portion of the gait phase, because that's where we have all that stress being put on the plantar fascia, which is then pulling on the heel. So that tends to be why that happens. So pronation can be, especially if you're someone who does overpronate, can be a bit of a situation where we end up in that kind of aggravating state, and that would be why that section of the gait cycle is so painful. Heel off to the toe off portion, that is where the foot is starting to supinate. So as we lift the heel, and then as we reach to the toe off portion, that is where we get that plantar flexion, we get a little bit of that adduction, and then we get that inversion of the foot to really push us and propel the body forward. So yeah, and then again, that is also creating even more tension, and that's why we need that plantar fascia to help stabilize the foot in the heel to toe off. Whereas in the mid stance or heel strike to mid stance, that's when we have the plantar fascia is using it almost more as like a force dispersion, right? Like as I've said there, to help stabilize the foot itself. Okay, so we're just going to kind of touch on some kind of common pain issues or kind of similar things that might be happening in the foot and what can potentially be going on. So these are the locations. So red, obviously, this spot right here. So that's something called a Morton's neuroma. That's a pretty common area that we can see some pain, usually between the second and third, or third and fourth toes, right in the actual foot portion itself. Okay. And then we'll have the purple section, which is over here. So that's usually where we see that bunion, hallux valgus. So that's just kind of the fancy way to say bunion. The bunion is usually the outcome of hallux valgus. We can have really mild hallux valgus without having a bunion. Bunions occur when it gets really bad. So that's when like the big toe is like really pushed in. That would be more hallux valgus. Hallux also just means big toe, just so you guys are aware. Hallux rigidus is going to also usually show up and around here. It can be a little bit over here as well, but more traditionally kind of right on through here, as where the purple is. And again, that's just when the big toe, so if this is our big toe here, it just doesn't like to extend. It has limited flexion. It doesn't have good motion, hence the rigidus aspect. Just like it sounds, big toes rigid. Okay, so yeah, that's the top of the foot, usually where we're going to see a lot of those pain patterns. Bottom of the foot, so that plantar surface. So again, Morton's neuroma, we're going to feel that same kind of spots right in through there. The blue one, metatarsalgia, so that's right in through here. That really is just pain of the metatarsals. So those are the bones, those like long spindly ones that reach out to the toes. That's the joints of those can get irritated for whatever reason, the muscles between them, any pain that we really can't diagnose what's actually going on. It's not an Morton's neuroma, it's not a fracture, nothing like that, but we have pain kind of in that area, just kind of gets lumped into metatarsalgia. Green, so we have this one over here. So this is sesamoiditis. If we look back at the initial ones, I'll see if, yeah, not really. So on the bottom of the big toe, or at the base of the big toe, right in through here, there was two little bones. They're like little balls. They sit roughly right there and right there. Those can actually get irritated. So if those get irritated, that's where we get sesamoiditis. So sesamoid bone, the patella is actually, so your kneecap is actually a really big sesamoid bone. It's not really attached to anything. It sits within muscle or sits within tendon. Sorry, not within muscle, it sits within tendon. So same thing. So the big toe flexors run right along through here, and the sesamoid bones are like kind of points of, kind of like a pulley system in there. So they allow for a little bit of extra motion, or to kind of allow it to roll across the bone a little bit better. So in through there, right there. So if those bones do get irritated, which bones can become irritated, they can get inflamed and it can actually become quite painful, especially when we're standing or when we're walking. And we move down. This is probably our most common thing that we see, especially at the clinic. I've seen a couple Morton's neuromas, and then a lot of plantar fasciitis. So again, kind of gets lumped into any time you have pain along this general area, this being our common one, but really anytime that we have kind of heel pain to like mid-foot pain, it just kind of gets lumped into plantar fasciitis. Virtually all this stuff is treated pretty similar. So even if the exact diagnosis is not quite right, it tends to get treated fairly similarly. So it's not usually the end of the world. But yeah, so the plantar fasciitis is just inflammation of the plantar fascia. So that is just a big sheet of fascia, which is like connective tissue that runs from the calcaneus, which is the big bone back here, the heel, all the way to kind of a base, like where the balls of the feet start. Okay, so right along through here. And again, that plantar fascia just allows us to kind of control the foot, allows us to help with running, walking, stability within the foot, and things like that. Heel spur, so we have that down here. So again, that's just right where it tends to actually be, right where the plantar fascia starts and where it attaches to the heel. So if plantar fascia gets really, really bad, what can happen is that it's tugging on the bone so hard that the bone responds by actually creating a spur. The bad side of that is if the spur starts pushing into the fascia, we can actually have it where the spur will actually start to wear away the fascia, and we can have it potentially break, which is not ideal at all. But yeah, so that tends to be the heel spur aspect, plantar fascia right there. And that's kind of why we see them, that they're overlapping a little bit. So yeah, that would be the pain patterns for the bottom of the foot. And then we'll just kind of touch on overpronation and oversupination. Those are pretty common things that get kind of thrown around a lot. So just so we know, like, what can kind of come from if we are somebody who overpronates, or if we're somebody who oversupinates, or we're just a neutral walker. So with this one, so think of this one here would be your left foot. This one would be the right foot. And then this would just be normal, okay? So with an overpronated foot, the inside portion of the foot actually kind of falls in. So a lot of people who are, let's say, they get told they're flat-footed. They tend to be overpronators as well. Or if you truly are someone with like structurally flat feet, then you tend to just inherently you'll overpronate. So the ankle will kind of fall inwards. We get kind of this unleveling of the lateral malleoli. And then from there, we get a little bit of a change in deviation from the Achilles. So naturally, the Achilles should run relatively straight, as we can see with this one. But if we're overpronating, we're putting more tension on it. So then we're at a higher potential risk for Achilles ruptures, things like that. So yeah, overpronation, arch collapses inward, alters the angle of the Achilles tendon medially. So medially would be towards the midline of the body. So this way, towards the midline. Okay. Oversupination, again, this one a little bit more common in, like it says here, people with the high arches or really, really tight calves or a tight Achilles. So with this one, the foot doesn't actually roll down into what it should properly do for pronation. So it stays supinated, and we tend to walk more on the outside of the foot. So we're not dispersing force really well through the foot as we walk or as we run. So again, we see that Achilles tendon kind of deviate a little bit more to the outside and then travel up medially again, as it normally should. But again, it's just more tension on the calf, more tension on the Achilles. And with that being said too, the Achilles and the calf plays a pretty direct role with how the plantar fascia works, because that where it attaches into the back side of the heel, more tissue kind of runs underneath and then works its way into the actual plantar fascia itself again. So if we have tight calves, or if we have someone comes in with plantar fascia like issues, one of the first things we do, obviously we're working the bottom of the foot in the clinic, but we're also working the calf. It's almost a guarantee. There's usually a tight calf that goes in hand with a plantar fascia issue. So yeah, that would be the overpronation versus oversupination, and kind of like what exactly is going on. Okay. So yeah, here we go. So how your feet and ankles can affect the knees or the hips. So if we do have that lack of dorsiflexion, so when the top of the foot moves up towards the shin, that can lead to just compensatory. It leads to a bit of knee valgus. So that's when the inside of the knee actually will kind of angle towards, here, I'll grab the leg so we can kind of see, make this a little easier. So with knee valgus, so we got the right leg again, this section of the knee will actually kind of go in like this. So we create strain on the inside ligaments and tendons of the knee, right in through here, okay? And then that can lead to a little bit further hip adduction. So then the hip, to again compensate for that, will bring kind of more inwards. So the femur itself, rather than being relatively vertical, it'll move in more like this. So that puts more stress on the hip itself. And then from there, we can also end up with getting knee pain. So pain around the patella, because we're changing the joint line and how the actual, the quads and the patella are able to track within the groove. So right through here. So if this guy, well, you can't really see the patella, so he's right here. So if this is moving, so if the quads flex, usually it'll pull upwards, and then as the quad relaxes, it falls back down, okay? But if our quads are tight, or if we have this situation where we're having a bit of knee valgus, so the knee's moving in this way, now the patella is gonna rub more so on the big bones where it actually should be tracking through. And that's where we get that pain, like kind of patellofemoral pain syndrome. It can also lead to IT band issues. And then long-term, or if we're like a high, or more of like in an athletic population who are maybe playing sports or things like that, that's where we can potentially see a lot more MCL or ACL injuries potentially coming around as well. Yeah, and then overpronation, again, knee valgus can come along with that, and the same thing can occur with overpronation too. Okay. So yeah, ankle caves in, puts stress on the medial knee and then the lateral hip as well. So yeah, pretty similar as far as like what happens if we have a lack or too much of it. Okay. And then pain in different areas of the feet can just alter how your gait occurs over extended periods of time, which then can transmit to the other hip or the other knee, because now we're changing, we're having a longer stance phase or a shortened stance phase on the bad side to allow for, to avoid the pain. Okay, so this is where it gets fun. This is my favorite part. We get to talk about the exercises that we can do at home or things that we can do in the clinic, okay? So right at the gate, like I said, one of the first things we do is we always work the calf. So this is where we have our standing calf stretch. So if we have a step or something like that, we can just put the balls of the feet on the step, and then we just slowly lower the heel down off of the step, just to give our calf a nice stretch, okay? Knee to wall. So with that one, what I tend to do is you'll kind of get into like a lunge style position or a kneeling position with 1 foot forward. And then you start with the toes pressed against the wall, or like just kind of meeting the wall like that. And then we just kind of gently glide the knee over the toes. That'll again provide a nice stretch for the calf. And then we can kind of work our way back. What we ideally want is about 40 to 45 degrees of dorsiflexion. So again, when that foot is flat on the ground, that's going to be the shin bone moving forward. Okay, so we want about 40 to 45 degrees. And that usually works out as kind of like a rough estimate of that having the foot about 4 inches from the wall. So easy way to kind of track that. It's kind of what I do in the clinic. Just hands up like this. I base it kind of off the width of my fingers. If you have really small hands, then maybe that won't work for you. But roughly, I know it's about 4 inches. So for me, that's kind of my gauge. Okay. Yeah, so knee to wall stretch, it's a really good one. So we can do it that way. And then we have a downward dog style calf stretch. So if we're familiar with downward dog, hands on the ground, feet kind of making like in like a A-frame type idea. And then we'll lift 1 foot off, put the back foot on top of the back side of the ankle on the other leg. And then just slowly press the leg that we're stretching, press that heel down to the ground. That'll give us a really nice deep stretch in that calf. This is one of my favorites. It can be a little bit intense, especially if we have shoulder issues. It's not gonna be one that we're gonna give you. Or if it's just an uncomfortable position for you, it's not gonna be one. The easier ones are definitely gonna be your standing calf stretch or your knee to wall stretch, okay? The other thing, and this is again, one of my favorite things to do, is just roll the bottoms of the feet with a golf ball, a lacrosse ball, a tennis ball. I actually had a patient recently who said they were using a rolling pin, which I thought was pretty fun. So using something like that, just to gently roll the bottom of the foot across that ball. So if we're having that heel pain or having that plantar fascia style pain, this can be really nice to relieve some of that tension. Let's say you just finished a walk and your foot's sore. Something like this can be really nice. Again, based off the size of the feet, it's gonna be pretty dependent. If you have like huge feet, a lacrosse ball or a tennis ball might be perfect for you. A golf ball usually works better for most people just because it's pretty firm, but it also isn't too big. So we can actually kind of roll in between some of the bones and really get in there really nicely to try to give ourselves some self-release and take away some of that pain, maybe between visits, or if it's just like a little tender and it's nothing really that's going on that's crazy, give you some relief just at home. Okay. So then we get to the exercises. So these ones are just to kind of help strengthen the feet themselves. One of the big things, especially with like overpronation or things like overpronation being a big one, and plantar fascial issues, is that the foot, as it collapses inwards with that overpronation, it's pulling on those, like that plantar fascia. So those muscles themselves, if we that are in the bottom of the foot that kind of help to stabilize the foot along with the plantar fascia, they can get fatigued. So that's one of the things that happens a lot of the times with like a really like a lot of shoes, unless they're like a wide toe box shoe. So like a shoe itself that has like a more, a wider toe box rather than like a narrow kind of dress shoe style shoe, or even still a lot of running shoes have fairly narrow toe boxes where we feel that pressure on the outsides of the foot. That can hinder our ability for the foot muscles themselves to really respond to their environment, which is why probably in like about 10 years ago, it started like the barefoot running style, or like those minimalist shoes that had the wider toe boxes. They had the narrow heel with like their big flare out at the toes. Those became more popular, and they're still becoming more and more popular just because people are kind of understanding like how important the musculature of the foot really is to foot health, knee health, hip health, and everything like that. So yeah, these are going to be help mainly for improving like toe proprioception, so how the toes respond to things, how the foot and the ankle respond to things as well. So yeah, passive toe spreading. This is just really nice. I do this stuff at home almost every night. And again, it's kind of funny, but just when I'm watching TV, I just my fiance has like the little things you put between your toes, like toe spreaders for when she's painting her toenails. I steal them and I put them between mine and just hang out there. It kind of does feel nice, especially if you are somebody who's in like a narrow toe box shoe all day at work, in your dress shoes or something like that. It can be nice, like when you get home, to really kind of spread those apart, and allow kind of that more natural feeling of the foot, as if we're just walking on like barefoot. Active toe spreading, so we're doing exactly that. So if this is my foot and we're just normally like this, active toe spreading, I'm going to forcefully try to pull my toes apart without touching them, just using the muscles to pull those feet apart. So again, a nice, easy thing you can do, just watching TV, hanging out at home, playing cards, whatever it is you do, and still be kind of training your feet a little bit. Big toe presses, toe curls with a band, things like that. A little bit tougher. The toe press isn't too tough as far as like what you need to do it. Toe curls with a band, obviously that's a little bit different. But the toe press, what we do is if we have our foot flat on the ground, let's say my index finger here will be my big toe. I'm gonna press that into the ground while lifting the other toes up. So the minute we do that, you'll notice if you watch your foot that the arch section of your foot will actually get a little bit bigger. And that's a good thing. That's where we're going to create that strength and create that support to help provide more structure to the foot. So we're not overpronating, or we're not getting as much tension into the plantar fascia, because those muscles are protecting the foot. They're not letting it fall. So that's going to be a big thing, especially as we're rehabbing someone with plantar fasciitis, which again, like I said, kind of focusing on that a bit because it's one of our most common things that we see as far as foot pain. And then, so yeah, big toe, and then we can do the same thing. So if this is, again, my big toe here, I'm going to lift my big toe up while pressing the other toes in, and the same thing's going to happen, but rather than it be right at the inside portion of the arch, we'll notice more so to this portion of the arch is going to start to pop up a bit. So again, same premise, the same thing. Another really easy thing that we can do, watching TV, kind of playing cards, whatever it is we do. Towel scrunches or marble grabs, this can be a fun little game. So as far as the marble grab goes, get a little like bag of marbles if you have one floating around, even if you use them for like decorative purposes, like when you're like in your florals or something like that, or if you have kids who still play with marbles, grab like 10, throw them on the side, and then literally all we're doing is we're just using the toes to just try to pick up the marble, and then we just move it to the side, put it down. So you can put a little Tupperware thing, whatever is kind of, you can make it a game. Try to pick up one, put it down, pick up the other, put it down, pick up the other one, put it down, and just transfer them, and then do both feet. The towel scrunches. So we would just lay a towel, like a face cloth size towel or a hand towel size. Lay that down and just start at one end and just grab the towel with the toes, pull it back. Grab the towel with the toes, pull the toes back, just like that. And we just move the towel back towards us. Usually takes about 10 to 12 times to move a hand towel length towards you. You might have issues like getting right when you start it. It might take you way more than that just because you don't have the dexterity of the toes to really grab and pull. But that's the point of rehabilitative exercises. Sorry, Kevin is back. Kevin is my cat. That's the point of those rehabilitative exercises, is to help train us to make it easier for us going forward. So if you start and it takes you maybe 20 tries, but in 2 weeks, it takes us 10, that's improvement as far as like the dexterity. And hold on, I'm just gonna put him down. Go away. Okay, so yeah, that's improvements in those aspects, which is really important. And then again, so if you're coming to the clinic and you have something going on, kind of what you can expect to usually occur at your appointments is going to be a lot of soft tissue work. We tend to do a lot of that, especially if it's like a plantar fascial issue. Sorry, excuse me. Or if like even with Morton's neuromas, I've had good results with Morton's neuromas, just doing soft tissue work. If it's a point where we're finding that there's maybe a lack of mobility in the ankle, we can always do some joint mobilizations or joint manipulations. So that would be where like the chiropractic side of things come in, is that we can actually adjust certain bones in the foot to provide us a little bit of relief if we're having pinching or any pain with certain movements. Personalized rehab programs. So with that being said, a lot of what I just told you is what I kind of go forwards with, kind of your intro rehab or intro prehab to kind of prevent things or to help kind of bring things back to where they should be. Or this is one of the first things that I do is kind of those exercises that we just chatted about. But once we kind of finish with those are things that I'd like people to do for a long time. But then it's adding other things in that maybe one person's ready for, but another person's not. So it's where we can kind of find that nice thing that we make it for you, we make it yours, and we're checking in with things like that. So whether or not that's with one of the chiros or one of our physiotherapists or anyone really in the clinic who you might be able to see. The other things we have is a laser therapy and the shockwave. So the laser gets in, it's a low level light. So it gets in, all you're gonna feel is just a little bit of like heat really at the surface of wherever the laser is. It gets in, it helps to stimulate the stimulates the cells within the tissues that we're working on, which can help them to kind of heal and regenerate at a bit of a faster rate. The shockwave, this one's going to be tends to be a little bit more uncomfortable. I don't want to say it's painful. Some areas can be, and some people will say it's really painful. Some will say it's a walk in the park. It's really up to the person. But shockwave, it's going to go in. It's a lot. It's like a little, kind of like a little gun, in all honesty. And as we put it on the tissue, there's a piston inside that hits a force plate, which sends a shockwave into the tissue. So it helps to disrupt scar tissue or any issues that might be going on within the muscle or within like the connective tissue or soft tissues of the foot. Shockwave has fantastic results with plantar fasciitis. It does really, really well with it. So yeah, just another thing there. I should have also said, the shockwave we only have at the Willow Park location. So if you are somebody who does go to the Westman location, the shockwave, you would have to go to the Willow Park one. The FootMax system, which is also, we also only have that one at the Willow Park location. This is where we can kind of get you to walk across a force plate and we can see how your gait cycle is, where do you overpronate, do you underpronate, do you supinate, oversupinate, things like that while we're taking our steps. And then we can kind of build you, this is how your gait is, this is maybe some things we have to work on, or what it's doing is just kind of solidifying what we thought. Okay, you do overpronate. Like these are the things we have to do to kind of fix that. And then we go from there. We also have the ability to order custom orthotics just for you, which is also pretty nice. If you're somebody who does like orthotics or really does want to kind of utilize the orthotic aspect of things too. So yeah, that pretty much wraps up the whole introduction or the whole kind of lecture. So this is where we kind of open the floor to everybody. And if you have questions, pop in the chat and we'll go from there. Okay.
Oh, did you catch any of that? I was talking without any, I think I was on mute. Did you grab the, I was rambling while on mute. We do have one question. I apologize about that. How do you treat a bone spur on the top of the foot?
So let's see. So it kind of depends where the bone spur would be on the top of the foot. I don't want to ask you too many personal questions because this is obviously a public forum. Oh gosh, there we go. So yeah, depending where it is, it could be a little tough. Honestly, at the end of the day, kind of once we do have bone spurs forming, there's not a ton that we can do to stop it from furthering. It would just be kind of managing that pain. decreasing the tension of the tissues that are on or around that bone spur. That would be kind of the biggest thing we can do. And again, I don't want to inquire too much into where on the foot, but let's say like if it's at the big toe, that becomes like kind of a sticky spot, because there's, again, we just kind of have to work around it and try to, again, just decrease the tension of the muscles that are around that spur to prevent it from growing or to prevent it from getting worse. And so that way everything around it can kind of stay safe. Definitely an interesting question. Yeah, not, again, without knowing exactly where, it's hard to say. If it's in the ankle, it would be, again, just kind of try to work with it, because we can't necessarily get rid of it. We can just try to prevent it from getting worse.
Thank you for that, Dr. Kurt. So the best way to treat really would be coming into the clinic for an assessment as well. So then you can have that one-on-one with a patient, wouldn't it be? Because it's such a unique.
Yeah, totally. It would be definitely like wanting to kind of get a gauge of where it is, how bad it is, what's it kind of pressing on potentially, or what's kind of around it. But yeah, that would be, it's definitely a good place to start.
Okay,
but like I said, it's not, we can't get rid of the bone, unfortunately. That would be more like going to like a surgical aspect, but I think definitely working with someone at the clinic or something to kind of help try to prevent you from needing surgery might be more beneficial than just taking it out.
Okay, great, thank you. There's a question, is Dr. Kurt a podiatrist? No, Dr. Kurt is actually a chiropractor who specializes in soft tissue injuries. Would that be correct? Is that a good definition?
Yeah, definitely. I've done a few extra courses just kind of on foot health. Definitely not a podiatrist though. I am not a medical doctor. I am a doctor of chiropractic. So yeah, I'm not a podiatrist.
Perfect.
I find feet interesting, but I'm not that interesting.
There's another question that goes to that. If a big toe is leaning over into the next toe, does the person need surgery, or is treatment the best way, say coming in for treatment? I guess the question's kind of, is it best to come in for treatment and then get some exercises at home, or is it a combination of all three? Did that make sense?
So right out the gate, depending how bad it is, even with treatment and like things that we're gonna like that we could do, we're not going to change how much that toe points in. The biggest thing that we can do is kind of to help, again, decrease that pain, improve functionality, things like that. Unfortunately, once that toe starts to point the other way, it's more than likely going to stay that way. The bunion size will probably stay fairly the same as it has been. It's just stopping it from progressing. What I will say again is that if the toe is really kind of valgused or bunioned or pointing in, it may be you may be a surgical candidate, you may not be. I've had a patient who's had their surgery done twice, both with pretty limited outcomes. So it's a tough surgery. It's a really kind of painful kind of recovery. So I think using that kind of as your last resort is definitely more so the way that I would go. This patient that I had, she saw me after the surgeries. So, and we did kind of help a little bit as far as like decreasing her pain, kind of regaining a little bit of mobility. But it's definitely, and again, I treat conservatively. So I really don't like to push someone to surgery unless I feel like it's like, we've done everything we can do. I think your next avenue is a orthopedic consult for surgery.
Okay, great.
And then again, that's just, yeah. Sorry,
And
I kind of rambled there.
No, that's a great explanation. If the big toe is not causing pain, it's just more of a structural thing, that's where coming in for regular treatment and monitoring, if there is more pain, is probably the direction that one would want to go. Would you say that's correct, Dr. Kurt?
Yeah, like if you're not experiencing pain, like that's a good thing, really. That just means it's kind of like a structural change, and which isn't the absolute end of the world. We can still function. But again, coming into the clinic, maybe getting an assessment, you wouldn't need like a long, lengthy treatment plan. We're just getting an assessment, seeing how things are, getting in there, working some of those muscles, going over some of the exercises that we did talk about today, and giving you some like a really good kind of more prehab program might be a really beneficial thing for you if that's the case.
Fantastic, thank you. And thank you for the questions. While I was muted, I was mentioning that Dr. Kurt works at both Westman Village and Westman Village and Willow Park Active Sports Therapies. So you can find him at both locations. We would also like to remind everyone that for the month of May, Active Sports Therapy is offering a free gait analysis. I think Dr. Kurt had mentioned that on one of your slides with the foot max. So that's an analysis of how your foot strikes. In the event that you do need custom orthotics, and that is your preference, there's a $75 off custom orthotics for the month of May. All of that ends on May 31st. So if that's of any interest, Dr. Kurt's seeing patients, that looping back to the fact that we only have those machines at Willow Park, that can only be booked at Willow Park. So you can check the website and check the email that will be coming out shortly with the playback that can give you direction on that. What is the next thing? I don't see any more questions. So I guess we can wrap it up. Thank you so much for everything. If you're looking to review any information about the foot, that Dr. Kurt spoke of, or possibly want to share this lecture with a friend, the follow-up email will be coming in about 24 to 36 hours, and you'll be able to access all the information there, as well as links on how to book your appointments if you want the foot max gait analysis. And yes, thank you for your time and attention this evening. Stay tuned for upcoming lectures and workshops. We have one more coming in June, then we're going to take a break throughout the summer and get back at it for September. So we look forward to seeing you. We appreciate your time and attention. And thanks for everything, Dr. Kurt.
Yeah, my pleasure. And again, if anybody has like any questions or think of something after, reach out to the clinic. They can always forward emails to me directly or something of the sort, or just, we can always get in touch. So don't hesitate to reach out. We're always there for you guys.
Yes, we are. And Dr. Kurt's an easy guy to find. Thank you so much for your time. Take care.
Bye, everybody.
Bye.